everyone. I'm so glad you're here. If you've gone to other sessions, then you might be getting a little tired, or even if you've just been working today. But it really means a lot that you're here from the standpoint of trying to do the best at your job and trying to provide the best services for the clients you work with. And I really respect that. It was cool hearing Mary introduce me as Cary Hall because I am less than 2 weeks married. So Hall is my new name. Thank you, thank you. So yeah, today we're going to be talking about trauma-informed care, and the reason I called it "Do No Further Harm." Well, first of all, I work at a university, and with academics, we always have to have some kind of subtitle. Usually they're very long. I try to make mine at least interesting. But I was thinking about how, from a doctor standpoint, we have the idea of trying to do no harm. But unfortunately, when we're talking about trauma informed, a lot of times people already have harm. They've already had trauma or traumatic experiences. So you'll see that a lot of what we'll talk about today is how do we not re-traumatize or trigger. So a little bit about me. I work at the University of South Florida. I'm in the St. Pete campus. My major area of study is substance use and mental health. I worked in that field for about 20 years with people with criminal justice involvement because my degree is in criminology. So I teach all the crim students who think they want to go be in the FBI and be police, and I say, no, come help us be behavioral health. We need you. And even if not, if you go and still do the FBI or your law enforcement, I've been very pleased to see that a lot of them change their perspective to at least be more compassionate with the people they're working with. So today we're going to look at what is the definition of trauma, because it's actually kind of one of those strange words that means multiple things. What's the impact of trauma on individuals, which you may be familiar with, some trauma disorders, and the real key of what we're going to talk about today is how do we avoid re-traumatizing others with trauma-informed care, and how do we not be re-triggered or triggered ourselves? How do we make sure we're taking care of ourselves in this field? So we'll become familiar. There are very specific principles of trauma-informed care through organizations like the SAMHSA. Understand how you as peer specialists can ensure trauma-informed care for your clients. Obviously, there's only certain things that you are in control of. And how can you be mindful of your own trauma triggers to stay healthy and well? One of my passions that I work on a lot, I just did a training last week locally here in Tampa, is taking care of yourself, self-care, the science of self-care, the fact that we know that if you don't take care of yourself, what happens in the brain, what happens in the body. All right, so let's get an understanding of trauma. I know Mary said this, but since people are coming in, a few people are still joining us, please feel free to write in the chat or raise your hand or just wave at me if I can see you. As a teacher, don't like to just talk to people. I would like to hear what people think. And if you have a question, we don't have to wait till the end. So I mentioned trauma as kind of like an unusual concept. So if you look it up, you see things like a deep, distressing, or disturbing experience, emotional shock following a stressful event or a physical injury, which may be associated with physical shock and sometimes leads to long-term neuroses, and physical injury. So if you think about that, that's a pretty broad definition. If you said that to someone who really had no idea what trauma was, I'm not sure that they would get it. So I kind of break it up a little bit. We have this part where it's the subjective response to the event. And then we have the event, which could be an injury or a disturbing experience. It could be a brain trauma. We're going to talk about the ACEs a little bit. Those are adverse childhood experiences. So trauma, depending on where you look at the definition, it's the traumatic, it's the event, right? Like I got hit in the head, or it's the response to that event. And I'm going to lean more into the response to the event, and I'll
Yes, I said
explain.
that, Kimberly, you dumbass.
I assume you didn't mean that for me, Esther, so I'm going to mute you. So, the American Psychological Association, or the APA, talks about trauma as, this is the definition that I think is really powerful, an emotional response to a terrible event like rape, accident, or natural disaster. And so, if someone, well, I've been in situations like this. I've been in meetings or trainings where someone came in and put something really terrible, really hateful in the chat. So do we think that everyone who read something really terrible in the chat would respond the same way? No. Some people find it amusing for whatever reason. Some people have really no response. Some people think it's, they get angry. Some people might feel kind of frightened or sad. There's a lot of responses. And so the event is the same. The event is that this person has come in and said these things that are, we can pretty much agree are hateful. But really it's about how do we respond to it. So I like to break this down into the emotional response, the terrible event, and physically or emotionally threatening or harmful. So it's not just physically harmful, it could just feel threatening. So we have a lot of different responses. There's the fight or flight, which we're very kind of accustomed to hearing about. But there's also other responses that we're learning throughout. They're trying to stick with the F theme here. I don't know if we'll be able to do that always, but there's flood, fatigue, fawn, or freeze. And I'm going to go into those. So fight or flight is what we're most knowledgeable about typically. And this is, the whole story of you're in your cave and a bear comes by, right? When we look back in history. And so you have two choices. You're going to either fight the bear or you're going to run away. And our body responds as such. It takes energy away from things like digestion, or it also takes things away from our prefrontal cortex and our executive decision. So we don't necessarily have a lot of planning and thinking in that moment. We just either run or fight. And so you get more cortisol, stress hormone, you get more adrenaline, your legs, you can run faster, you can punch harder. I don't know if punching a bear is a good idea, but whatever you have to do, I guess. So that's what we're used to, and we'll come back to why that matters. We also have freezing. So sometimes you'll hear about something terrible like an assault, and the victim, they'll say, well, why didn't the victim do anything? And sometimes that is related to freeze, especially if someone has been in traumatic experiences in the past. They may just freeze because they feel very out of control, and that's their way to respond to the perceived threat. Another one is called fawn, which is like they placate the person. This is something you might see in like a violent relationship where the person who has typically been abused or hurt sort of tries to calm the person, and it's okay, and I'll fix it, and things of that nature to try to forestall the bad thing that they know is going to happen. Flood is being flooded with emotions in response to the perceived threat. This is also sort of paralyzing. And fatigue. I don't know if any of you have experienced any of these, but I sometimes have this fatigue where something bad happens and you just want to go to bed. I don't know how evolutionarily that would help me any. I don't think it would, but here we are, right? So before I jump into sort of types of trauma, I want to circle back to two things I mentioned. One is the ACEs. So I don't know if everyone is familiar with this, but the first time that there was like a very widespread study of basically, they call them adverse childhood events, but it's basically trauma. This was done through an insurance company, and it was done with a very large population, especially for the time. And they looked into traumas like if there was abuse or neglect in the home, if one of the parents had a substance use problem, if one of the parents was in prison, things like that. And the more ACEs, so the more traumatic or adverse childhood events that the person had, the more likely they were to have substance use disorder, the more likely they were to have mental health issues, the more likely they were to be in domestic violence relationship. They were more likely to spend time in prison. So there were a lot of really clear relationships, and there's been studies that have replicated that over time. So I think we've known for quite some time, probably since the 70s, some of the impact of having these adverse childhood events or these traumatic events, particularly when in childhood. Now, the other thing I want to address before we move into types of trauma is this idea, and we'll talk about it more later, but that an event can happen and people have very different responses. Well, let me ask you guys, why do you think that something really bad could happen to all of us, the same bad thing, but some of us will respond with basically ending up with a traumatic disorder, PTSD or disorder of some kind, and others will be basically fine, and everyone else will be somewhere in between? What are some thoughts? I'm looking to see if there's comments in the chat, or you're welcome to unmute. Everyone responds differently. Natural resilience. I like this resilience. Brains are different, experiences are different. Great. I'll make sure I didn't miss any. I agree, Lisa. It's a check. Going back to the last thing, it's checking out. I don't want to be here anymore, right? Okay, so I see, in response to this question, natural resilience or past trauma. So that's really interesting. I want to come back to that. Age of siblings. Oh, so maybe in a caretaker role, maybe? Maybe ask you to unmute for that. I'm making some notes. Everyone responds differently. Upbringing, hypersensitive, difference of resiliency. I think I missed one here. Brains are different. Depends on the circumstances. Sure, absolutely. So tell me if you would be willing to unmute yourself and tell me what's the comment about age of siblings. I'm very curious what that means.
Yeah, I unfortunately was the victim of adverse childhood experience. It would have been called my whole childhood, but I was the oldest of three. Little sister was still in the oven, actually, so obviously I don't know how much it would have affected her prenatally. And my
Yeah.
little brother was too young to, you know what I mean, to fully experience a
I
lot.
see what you're saying. Okay. Let me ask you this, and I won't keep you on, I won't pick on you much longer, but do you think some of it, I understand your comment about maybe because they were so young, it might not have affected them in the same way. But, and I ask you this as the oldest child of six, who grew up with adverse childhood events as well. Do you think some of it was your sort of protection of the other kids?
Well, absolutely. And, the start of the event was a father leaving when I was 7, going
Yeah.
out to get a gallon of milk and a pack of smokes and never coming back.
Yep. Yep.
And so at 7, I was trying to learn what the heck mortgages were, what the heck property taxes were, what the heck, you know what I mean?
Yeah.
Because my mom lost it. And,
Right.
so whereas my little brother, who was 5, wasn't, he wasn't really
Yeah.
as dialed in. So, yeah.
Right. Yep. I definitely was in a position, I had a parent with a substance use issue. So I was very much like, I took on the role of the hero and taking care of everyone else. So interesting. I really love this answer about resilience. And I think that's a key piece that we'll talk about today. And it's not a criticism of anyone who goes through something and struggles, because that's normal. But what happens with trauma is that there is it overwhelms your coping skills. It overwhelms what you have available. And that can mean your support systems, your resources, all sorts of things. So one of the kind of blanket reasons that a person will have a stronger or a more negative, if you will, reaction to trauma is not having so much emotionality that it overwhelms their ability to cope. And so I think that's probably, like Lisa and I said, why we sometimes just shut down, right? So we'll talk more about what happens in the brain and why that matters. But I think it's really important because there's this idea of the trauma being the event. I think I have some new comments, so I want to look here. Oh, masking. Yes, that's a big one. Oldest is the protector. Body keeps the score is amazing. I taught a class with that as my text. It's great in the workbook. Yep. So, yeah, so I think it's just really important. I was actually on a podcast recently talking about trauma, and basically, you know, if your coping skills get overwhelmed, then one of the things we do is go to maladaptive coping skills. What are some maladaptive coping skills we're well aware of? Substance use, gambling, you know, all sorts of different things that are not great for us, but that we think in that moment are a good plan. So in terms of a couple types of trauma, acute usually results, sometimes called type 1. This usually comes from like a stressful or dangerous event. So I'm in Tampa. We have had many hurricanes. My children actually went through their home with their father being flooded in the middle of the night. It was a very scary, traumatic event. Thankfully, they don't have like a long-term, negative experience from it. Then you have type 2, which is chronic trauma. This results from repeated and prolonged exposure to highly stressful events. So this could be things like domestic violence, child abuse, bullying. Complex trauma, sometimes called CPTSD, is exposure to varied and multiple traumatic events. Often these are invasive and interpersonal. This can include abuse or profound neglect during childhood. And one that I really wanted to highlight for all of you is secondary or vicarious trauma. So as people who work with people in this field, as behavioral health, helpers, we often hear about our clients' traumas. And if you hear about and care enough about other people's traumas, it can actually get you to a position where you're experiencing symptoms of trauma as if that trauma were your own. So we want to be really careful that we're taking care of ourselves, that we are having a healthy detachment, that we're using some of the things I'm going to talk to you about today, because that is it's a real danger that we face when we're working with clients who share their trauma, and when you're a caring individual who kind of puts yourself in their shoes. So I mentioned that there was a big study in the 70s. They weren't calling it trauma per se, they were calling it adverse childhood experiences. But in terms of the history of things like PTSD, what really it was paid more attention to when people first came from back from Vietnam. And we saw a lot of people who were being treated for symptoms of their trauma, and they were coming back with things like substance abuse issues, depression. And so the moniker of post-traumatic stress disorder, that's when we started to hear about that. And people for quite a while only thought that was something that happened if you were in war. So now we can see with things like brain imaging, what happens inside the brain of people who've experienced trauma. And we're much more knowledgeable now of an imprint that is left on the mind, the brain, and the body. And I like this quote, that trauma results in fundamental reorganization of the way the mind and brain manage perceptions. So I mentioned that it affects your executive functions. So a lot of it is literally changing how you see things. So trauma changes not just how someone thinks, what they think about, but the very capacity to think and to communicate. So again, I think this is very critical when we are hearing stories or working with people who were traumatized, but they maybe didn't respond in a way that we consider normal for trauma, right? They weren't fighting, they weren't saying no. And so we have to keep in mind that this idea of not being able to even communicate what you're experiencing could be because of past trauma. So we talked a little bit about some of the differences. Trauma can have a lasting adverse effect on someone's mental, physical, emotional, social, or spiritual well-being. And not everyone who's experienced a trauma will have long-lasting effects. About 20% of people who experience a traumatic event will develop post-traumatic stress disorder, but other people may have symptoms that are just not quite to the point of PTSD. And I don't say any of this from a negative standpoint. You guys are probably somewhat I'm probably preaching to the choir because a lot of you understand this. Often when I teach about trauma, people are a little bit dismissive or they don't realize how impactful trauma can be.
Cary, there is a question in the
Yes.
chat. Can PTSD be the cause of domestic violence?
So that's a really good question. I love that. Thank you. So I'm hesitant with my experience with domestic violence to call anything the cause of it, because I really try to look at it as its own thing that people need to treat. And what I mean by that is we've had for many years, there's been an idea that, well, if you have a substance use disorder and you're a abuser, if you just stop drinking or using, you'll stop abusing, which is completely not the case. In fact, sometimes it gets worse. So do I think that treating PTSD in a person can improve the abuse? I'm sure it can, but I don't think I would call it the cause. I would call it maybe a factor, just because I think we have to be careful with, causation there. I don't know if I'm seeing all of the questions, so thank you for jumping in. So why do you think that some people, this is a similar question to before, but I think it bears repeating and it's specific here. Why do you think that many people who returned from Vietnam or other wars kind of broke down and had a lot of struggles and experienced things like flashbacks and difficulty sleeping and substance use, while others just kind of came back and went on with their lives?
Well, not everyone had the same experience. Some people were stationed at air bases while others were in the Delta. That could be one, but
Absolutely. So some of it can be like I experienced the hurricane that my children experienced, but I wasn't in, hip deep water, right? Like they were. So absolutely, that's definitely part of it. I'm seeing their brain, so that's a big one. So could the in terms of what their brain could handle, part of it could be the connections they had. Go ahead.
From all the vets I've worked with and grown up with, I'm a vet myself, although I never saw any action. I don't think that it's a matter of they don't have PTSD or did not see the trauma, but it's more their reaction or their ability to cope with.
Yes, absolutely. Great.
Because they
So
definitely did have that trauma in their life.
thank you. Yeah, I appreciate it, Craig. So it's they experienced the trauma. We don't have any question there, right? But it's what was the effect? How did they handle it? How did they, some people are mentioning like their connections, their support system, their childhood. All of these things are absolutely right. Risk and protective factors, great. Personal traumas that they've experienced prior to this, perhaps being in a high awareness or constant state of fear, loss of friends, different wiring. Just making sure I got it. Oh, sometimes it could be treatment they received upon returning. That's great. Some people are good at blocking things out. Some of it can be if they were in similar things in the past, so it didn't affect them, much as someone who'd never been through those type of trauma before. So I don't know if I got all of them, but there's a lot of really great ideas here. And so we're getting at the core part of the human, which is what is their brain capable of? What experiences have they had, almost from the standpoint of like a muscle, right? But also things like their resources. And when I say resources, I don't just mean like, ability to go to treatment or to get care, but things like what connections they had, what support system, and all of that is backed by the research. So you guys are right on. And I think to some of what Craig said, like, do you come back and see symptoms in yourself and get help then? Or do you sort of just go, well, this is, a lot of people are experiencing this is what it is, and then you live with it for a long time. My stepfather was in Vietnam and he never really got good sleep until he passed. He just really never was able to go to bed, lie down. He was always in the recliner and it was always an interrupted sleep. And it was, certainly from that experience. So some things that people do, and some of you will recognize this if you mentioned the body keeps the score. Some people feel only fully alive when they're reliving their trauma. So some people will put themselves in unsafe situations where they may end up experiencing trauma again. There's they increase their victimization risk. Basically, they sort of feel numb. And so there's this feeling of like wanting to feel something, even if that's a negative. So that's an unfortunate thing that we see in some victimization, some offender populations, and honestly, just some of the folks that you guys are working with in terms of substances and all of those issues. Now, what are some ways, I think a lot of times we think of numbing and we think of using substances. What are some other ways that we numb? Cutting, yep. Disassociation, social isolation. Sleep, food. Okay, here we go. Sleep as much as you can. Drinking, gambling, shopping, eating, sex, adrenaline. Exactly. Mindlessly scrolling through social media, work, overindulging, tattoos. So this is excellent. I got mine too, Lewis. It's okay. So that doesn't mean that any of these things on their own are negative, maybe cutting, but in general, it doesn't mean that any of these things on their own are negative. We have to have food, right? We use that example. But what we do often is we're using these things not for like, I'm mindfully enjoying my food, or, oh, I really want to get this next tattoo, or this is a person that I really want to have sex with, or whatever it is. It's, I don't want to think and feel, so I'm going to do this thing instead. I just developed for the university a course on what we call process addictions or behavioral addictions. You're probably familiar with them, even if you're not familiar with the name of that. And you mentioned a lot of them: gambling, sex, shopping, eating. It's really very similar to substance use disorders in that it's an escape, or it's a way to handle emotions. It's a maladaptive coping. And the action itself is almost irrelevant. It's really about, does it give me dopamine in the brain? What do I feel, so I don't have to feel and think about what it is that I've gone through or that I'm dealing with normally. I just saw a new comment. I'm trying to get down here. So you guys got a lot of great things there. Excellent. So in terms of prevalence, the majority of American adults have experienced some violent crime in their life. 12 million females in the US have been raped, and more than half of those below the age of 15 or below the age of 15, often incest. I'm teaching a class right now on sex offenders, and it's pretty disheartening. I try to stay positive, but we can see that, many of us have had, some of these terrible experiences. So what are some of the emotional and psychological responses that people experience if they have gone through? You may recognize some of these in yourself or in people you work with. We talked about feeling numb, feeling anxiety, depression, irritable, difficulty coping with how we feel, withdrawing from others. Someone mentioned social isolation, so that was really good. Flashbacks, nightmares, shame and confusion. And I'm going to talk a little bit about shame later, so we'll come back to that. But all different emotions that can come up. And I think a big piece of it is having difficulty sitting with those emotions and deciding or finding a way to cope with them. In addition, there are some physical symptoms that people experience. Things like being jumpy. I had I was a trainer at a nonprofit, and I had a gentleman who had to sit in the back row. He could not have anyone behind him. Hypervigilant, had gone through some trauma. Between you and me, I think it was mob related, but we don't know that for sure. But kind of in that constant state of alertness. I find in myself that loud noises are big. I get very jumpy. Like I don't necessarily, I'll think it's really loud, but no one else seems to react. So I'm like, I guess this is a me thing. But digestive systems can be an issue. So there's a lot of different things we experience physically. Spiritually, some people will struggle to experience things that they felt, joyfully, things that made them feel good before. Things that they felt spiritually in the past might be difficult for them to tap into now. Sometimes I did a training recently on burnout, and a lot of what happens with burnout, which is similar here, is just kind of a changed mindset. Like if you're generally kind of optimistic or positive, this changing to being more cynical and skeptical, and that's some of what happens here. Isolation and social withdrawal, guilt and shame, anger, hypervigilance, and a loss of interest in activities. So I see working with people with substance use are more inclined to have sexual trauma. Yeah, Craig, that's my experience as well. And sometimes you need to find new things you like. Yeah, that's we're going to talk a little bit about that. Thank you. So these are some cognitive symptoms, and this I find really fascinating, and you'll hear me talk about this throughout. I've mentioned it already, but the brain is literally altered by trauma. I think the reason, you guys will understand this, I think one of the reasons that I grab on so tight when I find science that backs what we already know is because so many people who aren't in the field with help, aren't helping, or social scientists or things like that, sometimes think these things are, they're new age, or they're not real, or they're not, whatever these terms are. So I really like to find things and show, look, people who go through these experiences, their brains are literally altered. Let's look at how let's look at why, so that I guess it lends an air of legitimacy to what we all already know. So obviously someone experiencing a physical trauma can have brain damage or issues with the brain being back to its normal. But things like malnutrition, if people are being neglected, or just neurocognitive changes because of the level of stress that the mind is under. So people might find it's difficult to sit still, to concentrate. This is a big one that I think we need to have compassion and empathy for, to control impulses and behavior. Remembering things, talking when they're experiencing stress, processing information that's being given to them orally, and organizing, setting priorities, and making decisions. So remember, that goes back to that executive decision or executive function that struggles when it's experiencing trauma. So that was some of the more, I'll say negative. We're going to move into some of the more positive. What can we do about it? What is trauma-informed care? Why, and why does it matter for all of you? So what trauma-informed care does is it shifts this focus from like, what's wrong with you? Why are you acting that way? To, what have you experienced? What's happened to you? And one of the things I love about a trauma-informed approach is it's not some difficult clinical skill that you have to have your, licensure to be able to figure it out or anything like that. Trauma-informed care should move for every level of an organization, whether it's the CEO, whether it's the person at the front desk. I'll give you an example that I think is really poignant with the front desk. So when I was running the residential facilities at nonprofit here in Tampa, I was housed in the men's facility. And one of the men was out at work and he came in sweaty, Tampa, gross, panting. Clearly he had worked really hard to get back to the facility. And the person at the front desk, who was not a clinician, gave him hell, basically. It was like, you're late, just reaming him. And I could hear it from my office. So I came out and I took him aside and I was like, it looks like you worked really hard to get here. Do you want a glass of water? Let's get you into group. And I talked to the counselor about the fact that, so now you're being parental, you're being judgy, you're telling this person they're not good enough, they didn't do well enough, which they probably have experienced at times in their life. And you're not encouraging this positive, like, I was at work and I'm on my way back here and sometimes the buses are late or whatever it might be. So it's really important that we have people at every level. By the way, she improved a lot and she became a counselor, so she's doing good. But, we want to make sure at every level that the goal is to reduce the possibility of re-traumatization and to reduce the, triggering of people. So that could be a very triggering experience for someone who was used to being yelled at or being, told they're not good enough. So our goal is to avoid re-traumatization, and we want to make sure we're not re-traumatizing our clients or their families when they come in, if we work with them, or our coworkers or ourselves. We don't want to re-traumatize anybody, right? And the great thing is, let's say that some of those people haven't experienced trauma. We're not going to hurt them by doing trauma-informed care. So there's no downside here. Anyone can benefit from it, and we can make our treatment facilities or our interactions safer and better. Okay, so the principles of trauma-informed care include safety, trustworthiness and transparency, peer support, you guys got that in spades, collaboration, empowerment, voice and choice, cultural, historical, and gender issues. And these might have a little different names and you'll see it listed differently in different places. So again, this is going to be, staff have to understand and assume that everyone they deal with could potentially have trauma. And you'll see this being used more, I'm seeing it a little bit more in healthcare settings, but we're also trying to use it in like criminal justice settings. You can imagine a lot of the criminal justice guys I work with are, they're not touchy-feely, so we're trying to teach them to not re-traumatize, but in a way that they understand. Okay, so I have been told, especially in children, it stunts their maturity growth to the time the trauma occurred. Is this true? And a change in the brain? So it's absolutely possible for there to be a slowing of the growth in the brain. It doesn't mean that they can't, that can't be improved, but absolutely, because what happens is people get stuck at a certain age in that fight or flight. So they're less focused on learning how to regulate emotions, learning how to problem solve, learning their verbalization. So yeah, there's definitely an impact, especially the younger the person. Good question, Kimberly. Thank you. And if you put a question in the chat and I don't see it right away, feel free to yell at me because they seem to like pop up and then go away really quickly for some reason. Okay, so what we hope is that when we adopt trauma-informed practices, we can improve patient engagement, we can improve treatment adherence, we can have better health outcomes, and we can also have better experiences as the providers and staff. Okay, Lisa, if someone is presenting at a mental health agency or recovery center, you can be pretty sure they have trauma and that staff will be geared towards recognizing that. But it's definitely important that others know this as well, especially as you mentioned in the legal system. Yes. I agree that we hope that everybody knows that if someone comes, they probably have trauma, but I don't know about your experience, maybe it's been better than mine, but not everyone behaves in that way, in my experience. And yeah, the criminal justice system is pretty, they re-traumatize all the time. And the thing that they don't understand is that they're making the facilities that they have to run harder to run because they're re-traumatizing people. And so they're making it a less safe facility, a less safe environment for everyone. So we're working on it. Is it really possible to stop generational trauma? Yes, yes, absolutely yes, 100%. Lewis is yes, completely. I think I'm doing it personally myself. I have children and we have an amazing relationship. They have not experienced trauma with their parents. They have not, oh, thank you, Lewis. Got some percentages there. Yeah, I think it's absolutely possible. But what do we say? If nothing changes, nothing changes, right? So if I do nothing to change my parenting style, if I just do what I learned, which is understandable, we do what we learn, then of course I'm gonna recycle and keep doing the same thing. It's nice, I'm not familiar with this number, but it's nice to hear Lewis said only 10%. Go for it.
Yeah, if you think about it, if everyone who was traumatized re-traumatized, we'd all be lunatics within 3 generations.
Yeah, but sometimes I think that might be the case.
Yeah, well, yes, well, that's arguable, but no, it's people are surprised that it's most of us, most folks try to do that. It's not a huge number, but yes, the people, it is generational, but it's not a huge number.
Thank you. I'm always going to be positive. I'm always going to be, assume that we can do better, but I also feel like I have, so that's a good thing. So I think that this generation, because I teach, 18, 19, 20, they're very engaged in their own mental health, their own self-care, trying to improve. So I think, just like a chronic disorder like substance use or mental health, it's not going to just improve, it's going to get worse without intervention, but with intervention, absolutely these things can change. So Shauna said, in my community, there's quite a bit of generational trauma. It's hard to change. We try to do better and learn when we get older and try to change why our parents are nicer to our grandkids. Yep. And I'll add to that in our moments of stress, we fall back on our old behaviors often. But if you keep practicing the new behaviors, then they can become the ones you fall back on. So instead of like I've certainly yelled at my kids, but I don't tend to yell at my kids now because I've learned over time a better way to communicate with them. So What are some of the goals? We know that the main goal of trauma-informed care is to not re-traumatize. We want to realize the widespread impact of trauma and understand paths for recovery, recognize the signs and symptoms of trauma in patients, family, and staff, integrate knowledge about trauma into policies, procedures, and practices, and actively avoid re-traumatization. So to the extent that this works for what you do for work, take it with you. If some of it is beyond what you work on, that's understandable. I was in a position for a while to help with putting things into place in terms of policies and procedures, and that was a really exciting, opportunity to kind of trickle down. Sandra says, it's a struggle. My trauma is triggered when dealing with a hard child to raise, and then I cry and I'm not always able to keep it together. Who can always keep it together, girl? I don't know. I understand. None of us can always keep it together. I guarantee you're doing great. But thank you for sharing. That was very vulnerable and honest of you, and I appreciate it. My first child was very easy. It was like a trick, and then my second one was the challenging one. Oh, man. All right. So the first principle we're going to talk about is safety. And you may feel like, well, of course we're going to make sure that our patients are safe, our clients, whatever we're calling them. But we want to make sure that people are feeling emotionally safe as well, not just physically safe. And sometimes we just don't think about certain things, like, does the place we're meeting have good lighting? Do we have good welcome common areas? Is there security if that's appropriate? Are we responsive if there's conflict? So making sure that, people can feel safe in the services. Our clients should also feel safe based on the rules and procedures. And this kind of goes back also to the example of parenting. If your rules are sort of wishy-washy and you don't really have consistency, that doesn't make people feel safe. So people need to know what the rules and regulations are and what the expectations are. That's part of feeling safe. And staff should feel safe that they are not going to be hurt in any way and that they're not going to have re-traumatization as well. So what are some ways, because I don't know all of your settings or how you necessarily meet with your clients, what are some ways that you either can or do make your clients feel safe? And what are some ways that maybe your current setup could improve? Yes, show empathy. You can answer that for every question, Josie, and I will say yes. I will cheer. Check in with peers on where they feel safe. That's great. And like, if something happens, debriefing, right? Do we feel okay? Are we all right? I did have a peer complain about the receptionist in the same way you mentioned. Yeah, unfortunate. I check in on a peer's level of anxiety when out in the community, empower them to leave anytime they want to. Great. I ask them if they feel comfortable enough to talk. I love that one, Laura, that's great. Let's see, I'm open with my clients to a point, respect where they're at, always. Create a safety agreement, establish clear processes and protocols to prioritize staff safety. Perfect. Going back to asking, I think that asking anyone, do you want input on this? Or would you like to hear what I think? Or things like that, I think are really, we're going to talk about empowering, but I think there's also a safety there too, that you're not going to just sort of throw at them whatever you want to. I also like sharing parts of your story that relates compassion. So I'm a safe person. I'm not going to judge you. I've been through things as well. Obviously, everyone has different comfortability with self-disclosure. Generally for me, if it makes the other person feel more comfortable and safer and it's for them, not me, I think it's okay. Some new comments. Making sure when sharing personal experiences, sharing is on a level that's not traumatizing to them. Great point. Michelle, I ask what safe looks like for them and ask how I can support them as they share these things with me. You know, take over, Michelle. Come on, you're the trainer now. Just ask, right? That is a great one. Just ask what they, and you know what's interesting, and I don't know if you've had this experience, Michelle, but like sometimes they're not going to know. Right? I mean, if you've never really been safe, if so much of your life has been in trauma, how do you know what that looks like? When I worked with people with domestic violence, when they weren't ready to talk about leaving the relationship, I would show them what's called the wheel of healthy relationships, and I would explain what each part of the healthy wheel was. And they'd kind of be like, oh, I didn't know that's what a healthy relationship was supposed to be. We don't know what we don't know. If you've never experienced a healthy relationship, you don't know. If you've never experienced safety, you might have to help them, you might have to give them ideas what that looks like. Where do you guys generally meet with as a peer specialist, where do you generally meet with the people you're working with? In the community at their houses, okay. So a lot of it's going to be your safety, right? Making sure that you feel safe. I generally was meeting with people, they were residential, so they lived in the facility, so they might come to my office or a common area. So it was more on me to make sure they felt safe. But it sounds like it's important that you guys feel safe where you're going. Hospital setting, side room, yep. Which also is really important for confidentiality and safety. Yep. Okay, great. Thank you. All right, so moving on, we're going to talk about empowerment. I can already tell from the answers you gave on that one that you work really hard to make sure your clients feel empowered, which is really impressive. So this has to do with making sure that our clients have some level of choice, that they get to, that their voice matters in the situation. And it's funny because people will think they don't have a choice even when they do, right? Have you had that experience? Like I used to meet every single client when they first came in, and I would do their assessment. And I would ask them, what's the longest time you've ever not used substances? And a lot of times they'd say something like, well, 8 months, but I was in jail or I was in prison. And I'd say, you can get drugs in jail and prison. You didn't. You chose not to. That, give yourself credit for that. Or you would hear like, well, I have to be here. I'm court ordered. Well, we weren't a locked facility. You don't have to be here because you're court ordered. You are choosing being here over the consequences of breaking your court order. And I think that's so important because so many people have been victimized. They truly have had situations where they didn't have a choice, but now they're almost choosing not to have a choice. And we want to give back that empowerment. Like, you do have a choice. You're choosing, not only are you choosing to be here right now, even if you don't want to be, but that's really cool. Like, give yourself credit for that. You can say, well, I'm only here because I'm court ordered, but do you know how many people came into our facility who were court ordered and just, ditched? I can't see the last comment. Trying to get down there. When the outcome is not a desired outcome, or when they're told they have to do something a lot of the time, I'm told I don't have control or I don't have options. Exactly, Michelle. So what do you tell them in that situation?
That nothing is a choice or an option, or choosing to do something, and kind of just as you were sharing, supporting them with understanding that their engagement is a choice, even if they've been told they had to do those things.
I think it's scary, right? Like when you realize that it actually is your choice, because as much as it sucks to be a victim, you can go, well, I didn't do it. It happened to me. But when you start making decisions for yourself, you have to sort of own what comes from that. So I think experiencing that discomfort with them of, no, you don't like the desired outcome, like you said, Michelle, but it's still a choice. Carrie says, I always ask what options or choice they might have. Yep. And a lot of times I find that when I talk to clients and say that, they're like, I don't have a choice. And I have to like remind them, I have to like push a little deeper here. So, oops, this is going too fast here. So some of it is how we communicate with people, especially if they are mandated to treatment. And, like I said, I worked with a lot of people where I'd have to remind them that, you do have a choice. You just don't like what the option would be. A lot of people choose jail over treatment. They don't have to. So what are some ways, if you haven't shared it already, that we can empower people we work with? And what are some ways that the setup maybe doesn't help us to empower people? Okay, so Sandra says, what can you tell someone to gain trust when they have been victimized by a prior peer support specialist or even a counselor or someone else they trusted that was there to help? First of all, that just breaks my heart. I would probably teach them baby steps. I think it's really okay for them to be skeptical, and probably smart for them to be skeptical, right? So if it were me, let's say, Sandra, you were telling me, I don't trust you, I've had this before. I would say, you know what, Sandra, that makes a lot of sense. If I'd been hurt by a peer support specialist before, I think it would be smart not to trust. All I can do is prove to you every time that we interact that I am trustworthy. All I can do is show you I'm a person of my word, show you that I'm not going to hurt you in any way, and just and hope that will sink in with you, which I think is powerful because you're teaching them a skill. We don't want to just trust. I'm pretty trusting, and sometimes it doesn't work out great. But, we don't want to just trust when we've been in situations where people have hurt us before. We want to have a safe radar and a safe boundary. That's another thing you might talk about with them is boundaries. Trust to an extent, but keep a healthy boundary until you feel like you can let someone in. Shauna says, always let the peer have the choice. That's great. No, thanks for the question. But what are some ways that, I don't know about you guys, maybe you don't deal with this the same as I did, but I remember things like audits. And we would have these audit requirements, and you'd have to have certain things on the treatment plan. Well, that's not empowering our clients. If you have to have ABC on every treatment plan, we're not empowering them, right? Do you guys deal with any of those kind of across the board guidelines? Okay, I see a few people nodding. So, I always really tried hard to do two things with that. I would try to, let me see if this comment. Yes, Michelle, great. Use a ton of open-ended questions. Yep. Motivational enhancement, baby. Love it. So one thing I would do, say that Mary was my client and I had to have A, B, and C on the treatment plan because of the Department of Corrections or because of whatever. So I would say, Mary, so, Department of Corrections is paying for your bed here. So they have an opinion on what your goals are gonna be. Let's take a look at them. What do you think of these? You might not like them, you might. What do you want to add on here? That to me is really important. We have to have these on here, and maybe they fit and maybe they don't, but what would you like to add? Because, we're just, again, that goes back to that safety and transparency, right? We don't want to go, no. When I was young, many moons ago, when I started doing this, I would try to convince that person, no, these are the goals you want, really. No, now I'm just much more upfront with, these goals may fit you and they may not. We can add to them. We can do things, but we live in the world where someone's paying for it, and if someone's paying for it, they might have some treatment plans that we have to accept. Does So Deborah gets it. She works on the ACT team where there's a lot of those kind of things, right? The requirements. And it all comes from good things. They're not, it's not like we're putting on the treatment plan that they have to hurt puppies or something. It's just that, it's just that maybe this person doesn't think their first problem is substance use. Maybe they think their first problem is their relationship or their mental health or their whatever, and we have to put that on there. So it makes it hard when you're doing motivational enhancement and you're trying to go with their goal, but you have to do a goal that is required. So, Linda, I asked them to trust one session at a time. Excellent. If they find they don't trust me to talk to me about it, tell them how they feel so I can understand what's going on. That's great. Again, I think all of those kind of things are modeling skills that not everyone has, and especially a lot of people in our populations don't have because they maybe haven't had trusting relationships or learned how to trust. So those are some ideas of things I've done because we're sometimes hamstrung. Same thing with like evaluations. I would have a huge evaluation to fill out, and the open-ended questions can handle a lot of it, right? We can find a lot of what we need from that, but sometimes you still have to go through and, hey, bear with me, I got to get this information. So, all right, moving on, collaboration. And you're going to notice that none of these are mutually exclusive, which I think is a good thing because otherwise it would be a lot. A lot of these work very closely hand in hand so that you can do them all to make it a trauma-informed care facility or relationship. So collaboration, we want to make decisions with the individual involved in sharing power, very similar to what we just discussed. And we want to work together to achieve desired results. So I used to do a treatment plan or do a note, and it was like, okay, here are the things you're going to do between now and when we meet next time. When I became more experienced, when I learned more about it, it became, here are the things you're going to do between now and next time. Here are the things I'm going to do between now and next time. Maybe they need resources. Maybe they had questions I couldn't answer, whatever, so that it's more collaborative. Now, they own it because, as we know, if I try to own their changes, then if Michelle knows where I'm going with this, if they do well, oh, well, look what I did. And if they do poorly, I get blamed. That's their changes, right? We want to make sure, but we're here to help. So we collaborate. Which just made me think of, I don't know how old you guys are, but it just made me think of Ice Ice Baby. Stop, collaborate, and listen. So how do you guys do with collaboration, and are there areas you could do better? I see 56 participants, and I know not all 56 of you have shared something. I'll tell you one time I'm not good at collaborating is when I'm really slammed. I'm really busy, I'm really stressed, and I just kind of want to get through the stuff, and I'm struggling with patience. That's when I'm not as good about collaborating and when I know I need to slow myself down. Laura said, I try to set a goal for each of us for our next visit. Awesome. It's not just on them, right? I meet up with my supervisor. He has an open door policy. Oh, that's great. That's really good, Sandra. That's one of my favorite things. I miss that in academia. When I was working in a treatment center, there was so much collaboration and so much team, and I loved that. And yeah, Laura, it could be something small. It doesn't matter. It just matters that we're trying to collaborate. All right. Oh, another comment. Supervision is always helpful. Talk to a caseworker. Yep. And sometimes a client will bring you a problem and you feel like it's your job to fix it, but maybe you say to them like, well, what have you done with this in the past? Has anything worked in the past? What do you think? Like sometimes they want to put it on you, but it's like, okay, let's brainstorm this. Michelle said, I usually ask what they want to work on that day. At the end of the session, ask what they want to try and do before we meet again. Great. Veronica, I think most of the time I've got to stay mindful of how full my plate is to be the best for each client. That's absolutely like that's when I have to slow down and be mindful, is when there's so much going on and it's like, no, collaboration takes too long. Like, I just want to get it done. I know what needs to happen, right? I think I saw something else right here above Michelle. Try to connect with the peer. I withhold certain personal information so I don't cause harm. Look at writing down their supports. I like that. All right, so this is near and dear to my heart, trustworthiness and transparency. So we want to make sure that this goes back to some of the things we talked about earlier. We want to make sure that they can believe us, they can trust us, that the policies and procedures are clear, that the boundaries are clear. I don't do something for them one day and not do it another day. I don't do something for one one client and not the other, right? Oh, and when I do several things during the day, I try to have one of them be self-care or meeting with a friend. You're getting it. You're ahead of me. You're good. That's good. That's great. So, one of my favorite experiences when I was running a treatment center was a client came up to me and was like, Miss Cary, I have to make a phone call. Just going. And I was like, is it phone time? No, it's not, but Miss Cary, blah, blah, blah. And I just was like looking, didn't say anything, just sort of looking, and they were like, okay, I'll come back at phone time, and walked away, because they knew these are our procedures and policies. These are my boundaries. I didn't give him a hard time for asking. I didn't get into it with him. He just kind of knew, and it was such a poignant experience for me, because it was like, if we do that enough, if you set the boundary, if you make it clear what's okay and what's not, then at a certain point, people realize and even start to do it themselves. Another example is if a client asks you if you can do something, being very honest if you can do that thing or not telling them, not giving them false hope, because then again, it's difficult for people to trust when you give false hope. Oh, Josie, don't panic with them. That's a great one. That is great. That for me was important, not just with my clients, but to the people I supervised, because they would come at me like completely panicked and I'd have to be calm. Okay, I'm really close to just having my future caseload as my only mental health service from needing a few mental health support several years ago, and graduated from case management last year, so graduation can be done. That's a lot. That's a lot. It's nice when things are a little calmer, although I think they just keep being not calm somehow or another, but excellent. But yes, I like this not panicking idea, because that's another way that we want our clients to trust us, is that they can trust us to be safe and not get caught up in the crisis of the moment. And say what we mean and do what we say. Okay, so cultural respect. I like the comment earlier, I think it was Michelle who said, just ask. So we can ask people, what about your culture, your race, your gender, your et cetera is important to how I treat you and how we move forward together. And you don't have to know every cultural norm for everybody. You have to know what's important to the person you're working with. And if you have your own biases, let me say that again. Since we have our own biases, let's, be mindful of those biases so that we don't act out on them. Asking pronouns, that's a good one, Deborah, thank you. We all have biases. It doesn't mean we act on them, but we have to be mindful of them so that we don't put our expectations or our prior experiences on people. So looking at being, how can I be sensitive, and is your culture, your race, your pronouns, your gender identity, are those things important to what we're doing together? You know, is that something that we want to put in the treatment plan, or that you just want me to be aware of and mindful of so I'm respectful? I see, let's see, oh, ask triggers. I don't know if I would ask the first meeting. I'm going to push back on you a little bit, just because you want to make sure that there's some level of relationship there. So you want to make sure that maybe they're comfortable before you're specifically asking for triggers, but you can, you know, ask them if there are things they want you to know, and certainly get there. Basically, if we're treating people with respect and humility, and we are appreciating what they bring to us, then, you know, we should be, for the most part, we should be okay. Schooling both my face and my words if a peer has a belief or practice that is contrary to my own. Yeah, I have a student who I've formed a nice relationship with, and she responds, she cannot like control her expressions. Like every time I'm talking and teaching, she's making these faces. I'm like, you need to get control of your face, friend. Okay, so when we look at ourselves through a lens of trauma-informed care, it's important to ask ourselves, are we transparent? Are we trustworthy? Do we use cultural respect? And can we do more? So with the, I go back a lot to the trustworthiness and the being transparent. So if one of my clients says to me, you know, my grandmother died, I grew up with my grandmother, can I go see her? Can I go to her funeral? I couldn't just say yes. I might want to, but if this client was in my facility on community control, on any kind of, you know, special probation, I had to get that approved. So I couldn't say, of course you can go, we'll make sure of it. You know, I had to say, I see the value in this, I see the importance, but I have to check with Department of Corrections. And otherwise, that could be so invalidating to any relationship I have with that client, that I'm like, of course we'll get you there, and then I can't. So I don't know if you guys have heard of this, but there's this thing called peer support that can be really great. Mutual self-help. And of course, these are, I kid, but these are important things for establishing safety and hope, building trust, enhancing collaboration, serving as models for recovery and healing, and maximizing a sense of empowerment. You know, just by basically your roles, you're really showing hope for people who are in the situations they're in, and you're showing them that you can make a change and you can empower yourself. You want this relationship to build mutual healing relationships among equals, regardless of if you're a peer specialist or if you're a counselor or whatever role you have. I always try to have an equal relationship that is non-judgmental, respectful, reciprocal, and of course, we always want to ensure that we're being empathetic. So the peer support model is a great part of trauma-informed care that is newer for some organizations or people. Okay, so we all know this goal, right? We're avoiding re-traumatization. And to make sure that we also avoid re-traumatization for ourselves, we have to be mindful of our own triggers. So now we're going to move into taking care of yourself. And this is not global self-care, although there will be a component of that, but this is really specifically, how do you make sure, and you can use these with your clients too, but if you have your own trauma that you're bringing to your role, how do you take care of yourself, knowing that you have that? So I mentioned growing up with a parent that has substance use disorder. There were certain clients in our facility that were just too close to home for me. Certain age of female with an alcohol issue, put her on someone else's caseload, because that was going to be very triggering for me. So, you know, we tend to have some of those things. the identifying those triggers is really critical to self-care and to be able to continue working in this field, because if we don't take care of ourselves, we can't continue doing it. So now we're going to discuss some research-backed strategies, and we're going to practice some to help us recognize and understand our own triggers. So one example is, or one step that's been shown to be helpful is using what's called a trigger log or an emotion log. You can decide if you want a physical one. I'm a pen and paper gal all day, but I know a lot of people aren't. I give essays in my class and my students are like this because they're so not used to writing. They're like, oh, my hand. But there are also apps, Mood Press and How We Feel are some examples, or it could be a spreadsheet. It can be anything you want. What matters is that you create this log and you indicate what happened, what emotions came up for you, what physical reactions did you feel, and what thoughts did you have. So some people are really good at noticing what they think. Some people are really good at noticing how they feel. Some people are very in touch with their body. A lot of people are not all of that, though. I have a friend who is in recovery from some really serious emotional eating, and she is very good at identifying what she needs to do and what's happened. But when I want to do breathing or want to do yoga or things like that, she's like, I'm not in my body. I'm not there yet. Like, I can't kind of look inward and be in my body. So it's going to depend on where you are with that. So in your trigger or emotional log, this is really powerful in terms of identifying triggers. You're going to record your emotions and what were the things that provoked those emotions. And what's nice about this, besides the fact that doing it itself can be really valuable, is that it also can help you look back and see patterns. So, oh, wow, every time this happened, or every time that happened, or I felt this way, you'll have it for a period of time. And I always try to give suggestions that aren't super difficult or cost money or anything like that. So what you could do is just record date, time, emotional state. So say you were feeling something during this training, you could put 4:30:25, you could put the time. I started to feel angry. And the situation was, the trainer was sharing about her childhood, etc. What's the intensity? Maybe it's a 1 to 10, 10 being like, I cannot handle how strong this feeling is, and 1 being, I'm fine. And like I said, how does it feel in your body? And this can be tricky. Not everyone is familiar or comfortable with this. So I'm sorry, Brandy, I don't have an app suggestion because I'm a writing gal, so I just do it on paper. But that Mood Press looked pretty interesting. So in terms of how it feels in the body, I ask my kids this when they're feeling things. In the belly, are you feeling kind of fiery? Are you feeling, are you maybe feeling flush or hot, right? Did something, there's lots of different ways. Sometimes people have tingling in the fingers, different things. And if you can, what's the thought associated with it? So we're going to talk about shame in a little bit. And a lot of times those thoughts are really, when we're feeling triggered, the thoughts can be very shame-based. So I think this is from Mood Press, Brandy. It looked pretty neat. Gives you your feelings, your moods, your, all of that. There's a lot of different ones. So I'm trying to look at, there seems to be a comment. Oh, was that a suggestion, Justin? All right. So after a couple weeks, you want to look at patterns in your log. Which emotions occur a lot? Do you notice, oh, wow, I'm frustrated more than I thought I experienced, or I'm, feeling shame, or I'm feeling angry, whatever it might be. What are the situations that trigger those emotions? What are the thoughts? That's such a key component. And is there a timing thing? And you can put things like, did you get enough sleep? I do that. I do have an app, let me look it up while we're talking, called, I think it's Evidation, Evidation, and it asks like how I'm feeling every day and how much sleep I got and what my stress level is. So I look back at that. And of course, you know, are you sleeping? Are you eating? Are you taking care of yourself? Will have a big effect on whether your triggers hit you hard. Now, when we talk about the thoughts, sometimes we don't think there's a thought associated. Like we think that there's just experience feeling. But there is a thought there if you pause and try to experience it. So this is also a good way to help you to slow down a little and notice what you're thinking. When I was running treatment centers and I would ask my clients, well, what did you think in that moment? A lot of times they would be like, nothing. I didn't think anything. And I would say, you know, that's kind of scary, but let's slow down and think about what the thought process was, because there is one. We just often are not in touch with it. So, good suggestions in the chat. Thank you. So I made this one up. I just put it on Excel. Date, time, what happened, how did I feel, where did I feel it in the body, what did I think, what was the intensity level. So, you know, you could do it any way that you want, easy. And there are journals that have a lot of this on them as well. Just kind of depends on what you like. If it's better to have it in your phone because you know you'll do it when it happens, then an app might be better. So you want to pay attention to your body. When you feel triggered, where does it land in the body? Lewis said, when things are disorganized, I get uncomfortable. Yep, meetings going off the rails, awkward social interactions. I think it cycles back to a need for control. Oh, preach. Every time that I struggle, it's because things are out of control. So, you know, maybe one thing I do for that is I write down, I draw a circle and I write inside what I can control, and I draw outside what I can't control. And I try to focus on what's in that circle. What's outside the circle is a lot more than you wish. So at the end of the day, I gather all the garbage in my car and throw it away to get rid of the stuff or trauma I may pick up from my peers, and I throw all that stuff away. I love that. That's awesome. Shauna said you might feel overwhelming hot flashes or panic. Yep. So where does it land in the body? It might be your heart rate goes up. Notice your breathing. That's a big one. Am I doing these really small, shallow breaths instead of like a regular or a nice deep breath? Muscle tension, especially in the neck, shoulders, or jaw. I recently had a pinched nerve. Lewis, you can relate. And I know it was because of what I was holding and not taking enough care of, you know, this area. Stomach discomfort, dizziness, feeling hot or cold. You just shared about being hot. Feeling tired, sudden lack of energy, nausea, and increased heart rate, Josie said, thank you. So good, some people are aware of some of that. Okay, so now that we are getting into recognizing, our physical symptoms, let me see what this comment is. We're going to practice something. Angry, yelling people, attempting to de-escalate them can be very draining. Yes, it can. It's very emotional. Just trying to stay calm when other people are not can be very difficult. Okay, so I'm gonna ask you guys to sit wherever it is you're sitting. I know a lot of you are multitasking, but if you cannot for about a minute, sit and try to get as comfortable as you can in your chair. If you're comfortable, allow your eyes to close gently. We're going to do a body scan activity. So start by putting your attention, your awareness, your mindfulness on your feet. Start noticing how your feet feel, how the contact with the floor feels. Notice if there's pressure. Notice how some of the weight flows from your legs towards your feet and pushes against the floor, or how the floor pushes up towards you. If you can notice how the inside of your shoe lies against your feet. Notice the temperature of your feet. Is there any tension or a feeling of discomfort? Perceive all of these things with curiosity without trying to change them. Move the scan from one foot to the other and notice if there's any differences between your feet. Now focus your attention on your toes, your big toe, the joints of your toes. Now bring that attention to your heels and then your ankles. Let your mind travel gently to your calves and shins, all the muscles of your lower legs. And just notice with curiosity how that part of your body feels. Let your mind travel to your knees, the joints of your knees, the soft tissue at the back of the knees. You can scan back and forth from one knee to the other to observe the differences. Notice if there's any tension, pain, discomfort. And if there is, just pay attention to it. Don't do anything with it. Don't try to push it away. Don't judge it. Just allow it to be there, whatever it is. Now let your consciousness travel further down your thighs. Feel the muscles of your thighs. Feel the chair making contact. Feel your clothes against your skin. Let your awareness gently move to your hips. Notice the pressure points where the weight of your body passes through you and presses against the chair. Allow your mind to move to your lower back, the muscles in the back, moving up through the spine to your middle and upper back, all the way up to those shoulder plates. Noticing how your back makes contact with the chair or not. Noticing all the feelings, those we would normally call nice and those we might call not so nice. Just feeling and not judging. Now allow your consciousness to go to your stomach, your abs, where all your vital organs are housed. Notice what feelings are there at this particular moment, such as the feeling of your breath. Let your mind go to your chest. Notice when your chest rises and falls from your breath. Notice any tension, anything you might feel, remembering that those feelings aren't right or wrong, positive or negative. They're just feelings. Allow your consciousness to travel all the way to your hands. Notice the feeling of your hands. Are they cool? Are they warm? Scan from one hand to the other to notice any differences in the feelings. Bring your attention to your fingers, the joints of your fingers, your thumbs, your palms, the back of your hands, your wrists. Now let your attention focus on your forearms, the muscles of your forearms, your elbows, joints of your elbows. Notice any physical feeling in that part of your body at this particular time. Move your attention further to your upper arms and then your shoulders. Notice the similarities and differences in your left and right side. Allow your awareness to move to the area between your shoulders and your neck. As we discussed, that's a place where a lot of feeling is stored. Might be uncomfortable, might be painful, or it might be pleasant. Just notice how it feels right now. Notice with curiosity. Bringing your awareness to your neck and those muscles, the sides of your neck, your throat. Move your attention further up to the top of your head, to your forehead. Notice every feeling in the part of your face. Let your attention travel to your nose, your eyes, your eyelids, muscles of your cheek, your other cheek, your upper lip, your lower lip, your chin, along your jawline, on both sides to both ears. Notice any tension stored in your jawline. Let your consciousness flow from head through the entire body. Bring your consciousness back to the breath. Take a couple deep breaths and then slowly begin to open your eyes. So this is one way not just to recognize physical responses, but to try to get a better relationship with our body and hopefully to relax it. Other things we can do is mindful breathing. We're going to do a breathing exercise today before we're done. Tension tracking. This is where you keep a log of any tension you feel in your body and what's happening when you notice it. Yay, thank you, Shauna. She said it was amazing. My yoga teacher training is coming up. I was a yoga teacher for quite some time, so hopefully now I want to take a nap. Hopefully I'm not losing it, so you can take a nap soon, hopefully. So another thing we can be aware of is our heart rate, learning to recognize changes in your body. I like that, having a relationship with your body. Yeah, it's crazy to me. I appreciate that, Brandy, how we walk around in this vessel, but we often don't pay attention to it somehow. That's okay, Lewis. There's lots of good ones online. So you can find, tons of really good body scans. I'm the same way. I start thinking and I go somewhere else. Yep. So temperature changes, we talked a little bit about that. You can note if you suddenly feel hot. When I feel shame, I feel hot. Immediately, like fiery. That's how I know it's definitely a shame reaction. Brandy said, most of us don't like our bodies. We have to have acceptance and a relationship. So I've been doing this thing lately where if I start doing something negative or judgy about my body, I have to say 5 good things about myself to myself. So if I'm like, oh, I put on weight, oh, these, fat, whatever kind of negative things we say, I immediately change my thinking and make myself say, I'm generous, I'm loving, whatever it is, because it's like we're bred to like not have a good relationship or not like our bodies, even though these bodies allow us to do all these amazing things. Energy levels, that can be a big one. If your energy level drops significantly, is that because something is taking it, something is draining you? So again, your log can help you, or even if you don't log it, even if you're just more mindful, even when things happen, if you're just more mindful, you'll begin to learn about yourself. So I came up with the example of if every time a certain coworker walks in, I sort of tense up, I can recognize that, try to sit with those feelings, and maybe over time I realize that coworker reminds me of someone who's triggering to me due to a former trauma, or, maybe it's something more current, but it will allow me to kind of sit with that and realize what is coming up for me. So thought patterns, this is huge. I think, we hear our own voice more than anything else, and we're so mean to ourselves. Like, it's so common to have this terrible self-talk. So listening to your inner dialogue, what is actually being said? Are we saying things like always, never, everyone? So does everyone, do this and I don't? Do I never get invited to hang out with these people? Whatever it might be. Noticing that self-talk And being aware, this is good for you and for clients. I did this with my students recently, identifying cognitive distortions. So are you someone who catastrophizes? Do you overgeneralize? I have a tendency from my background trauma to be black and white thinking. So either you are a perfectly trusted, amazing person in my life, or you did something and you're not. And it's not how I want to be, but it's something that I have had to be mindful of, that, I'm aware of ourselves. Yes, Deborah, we never talk to others like we talk to ourselves. And yes, Linda, the slides will be available. So, I really like to have my thoughts with the feelings, and see if changing those thoughts has an impact. Refocus, Josie, that's a good idea. So this one, I did this once. I was like, I don't know what was happening, but I was having some kind of emotional crisis. I was flying somewhere, and the person that I was worrying about what they thought of me or what happened, I couldn't talk to because I was on a plane. So I took a notepad and I wrote on one side whatever that belief was, right? This person hates me, this person's mad at me, whatever. And then I put all the evidence that supported that negative thought. And then I put all the evidence on the other. And the evidence for this crazy negative thought was very, very scarce, as you might imagine. And the stuff that said, no, that person doesn't hate you, was a lot more. So sometimes just looking at it on paper like that can be really helpful, because we can get pretty crazy in our own heads. Hopefully that's not just me. Hopefully some of you understand what I'm talking about. Consider alternatives. So this is another thing, I teach cognitive behavioral therapy. I'm sure some of you are familiar, where like you change your thought and it changes the feeling. So like I tell my students, okay, so if you're getting on the highway and someone doesn't let you in, what do you feel? And they're like, pissed off, screw him, blah, blah, blah. I'm like, what if you thought to yourself, that person's racing to the hospital because someone they love is sick? They're like, oh, I would be empathetic. It wouldn't bother me, blah, blah, blah. I'm like, you don't know the story. You're making up the story. Why not make up a story that makes you feel better? So, what are the other alternatives? Then this person doesn't like me, or I'm not safe, or whatever. And then someone just said this: would you judge a friend as harshly as you're judging yourself? Which is really a great one to think about. So this is an example of questioning the evidence. My boss hates me every time I see her in the hall. She barely says hello. I must have done something wrong. So the evidence that supports it: she didn't say hi to me in the hall twice this week. What contradicts it? My performance review last month was great. She's usually as direct if there's an issue. She seemed busy. Maybe that's why she didn't say hi. I've seen her not say hi to other people in the hall. So it's like a very simple, but I find it to be a very effective way to just kind of remind myself that just because it's what I'm telling my brain doesn't mean it's true. Lisa said, I do that changing the story behind my thoughts about someone's actions. I need to verbally say the revision if possible at the time. That's great. Yeah, I can really believe some crazy stuff I make up in my head. All right. So challenging and reframing negative thoughts. So we can take perspective. We can look at perspective taking. How might someone else view this? So maybe in that moment, if you can't talk to someone who could be like, no, that's, you're thinking crazy. How would someone else look at this? Replace extreme thoughts with balanced, realistic ones. Develop and practice some positive affirmations. When I was going through a particularly difficult time, I had the mirror, the closet, everything was positive affirmations. And, it can seem, again, silly or new agey, but I think it can really help when you're in a negative way of thinking. So some other things we can do to try to do trigger management. We just did something that was pretty grounding, getting into your body, getting out of your mind as much as possible. Other things are breathing techniques, of which I'll teach you and practice one. I'll show you some other grounding techniques, and cognitive restructuring, which is basically what I mentioned, where you change the thought, especially if it's a thought so much of what we are thinking, we're making up, right? We don't necessarily have proof or evidence. So how can we change that thought? So an example might be even something that's true. Maybe I was supposed to do a training today and I messed it up. It was not my best training. Being able to cognitively restructure that the expectation for myself can't be perfection, that we're all going to have rough days. Okay, so breathing is like magic, y'all. I mean, if you are finding that you're in this high cortisol, stress all the time, can't come down kind of thing, doing some controlled breathing can lower your heart rate and blood pressure, reduce those stress levels that can make you feel in fight or flight, increase the supply of oxygen to your brain, and stimulate your parasympathetic nervous system, which basically is like telling your body you're safe, it's okay. So one of my favorites is just a really simple inhale, and then you take a long exhale. You really try to focus on long exhale. That's a very simple one you can do anytime, anywhere, without anyone thinking you're weird in the car and whatever. Are you guys familiar with the box breathing technique? All right, so we're going to try this for a couple rounds and see what you think. So just before we start, what we're doing is I imagine in my brain this box, and we breathe in as if you're doing this whole top line. Then when you have the breath in, you hold. That's the second line. Then you breathe out. That's the third line. Then you hold again. That's the fourth line. So I always imagine the box in my head while I do it, even though I've been doing it for years. So find a comfortable seated position. If you cannot do anything else for probably 30 seconds, we can practice this a few times. I'm going to demonstrate, but your breath might be different. So after I walk you through it once or twice, I'm going to let you do it on your own. So taking a nice breath in, holding, exhaling out, holding, inhale, holding, exhale, holding. So do that a couple times with the rate of your breath. And wrapping up your last box breath. Excellent. Another one that I like for those of you especially who don't like controlled breathing, and by the way, someone mentioned in the comments that they get panicked or anxious when they do controlled breathing. I've had that experience as well, so I definitely understand, but hopefully it's something that maybe you can work through to be helpful. But if not, grounding techniques are another really great thing. This has been so helpful for me, and it's so basic. You just, like, say you're sitting in your office and like you just had a really stressful situation and you're having trouble coming down from it, or you're home and something, whatever. You just look for 5 things you can see, 4 things you can feel, 3 things you can hear, and 2 things that you can smell, and 1 thing you can taste. And sometimes I get it wrong because I don't have the paper in front of me, but they just do it this way because 5 is probably, it's easy to see 5 things than it is to be tasting 5 things at one moment, right? But there's something about just looking at what's in your environment, feeling what's in your environment, hearing, what am I actually hearing, that brings you back to that present moment. So we're gonna finish up with cognitive restructuring for long-term change. Yeah, Pamela, I mix the order all the time. I don't think it matters. So we want to try to not just manage triggers and responses in the moment if we can. We want that, but we also would like to have change that's, you know, sustainable, right? So if we identify and challenge our negative thought patterns, then we're going to be in a better situation to handle trauma triggers. And one of the things to look at is those cognitive distortions that we mentioned earlier. So, you know, look at what are the thoughts that arise when these things happen and what are some patterns that you see. Try, if you can, to replace negative self-talk with positive affirmations. I gave you an example that I sort of made up, right? I notice myself being critical of my body and I say 5 things that I like about me. So, you know, you have to notice you're engaged in negative self-talk, otherwise it doesn't work. Choose an affirmation, hopefully that directly counters what you were just saying. So maybe you don't like how you were with your client today. Maybe you can say something like, yeah, that wasn't perfect, but I'm a great peer specialist. Or I care a lot about what I do. I'm passionate about what I do. I'm always trying to improve. Keep them realistic and specific. Use present tense and first person language and repeat them daily, especially if those triggers come up. And one thing that's really nice is my hope is when I start to go do something to think negatively about my body, I'm instead going to have those 5 positive things come up for me. You know, we can change the pathways in our brain. So I mentioned that I wanted to talk about shame. I'm sort of on a shame campaign. We talk about guilt and shame sometimes in treatment of substance use disorders, but I want to bring up, if you're familiar with Brene Brown, she does a lot of work on this. Guilt is actually adaptive and helpful. Let's say that I went to teach class tomorrow and I didn't prepare very well and it didn't go great. If I say to myself, that sucked, I need to do better next time, I need to spend more time preparing for class, then the odds are I'm gonna do what? Anybody? Yeah, I'm gonna do it, right? I'm gonna spend more time preparing for class. If, on the other hand, I say, I am so stupid, I'm a terrible teacher, am I gonna do anything conductive, like productive and positive? No, it's very much counter to improvement, because if I tell myself I'm stupid or I'm bad, you can't change stupid or bad, right? You just are those things. So keep in mind that sometimes when we think we're being motivating, we're actually being demotivating. So if that voice is telling you you're bad, that's not a voice that's helpful. If a voice is telling you you could do better, or here's what I want to do better, that is guilt, and that is adaptive and positive. Shame is linked to things like addiction, depression. It's not constructive, it's not positive. So I hope that you will all be mindful of that for yourselves and also for when working with your clients. It's really an important thing I've been talking to my students about. They'll notice that their self-talk is like, oh, you're an idiot. The short version is, guilt is I made a mistake, shame is I am a mistake. And we don't want to do the latter there. Okay, so wrapping up, and I see we're really good on time. Remember that trauma-informed care shifts what's wrong with you to what happened to you. And so there's nothing wrong with you if you're being triggered. Something happened to you. And you can impact what happens to you next and what happens to your clients next. I'm going to say thank you, and then I'm going to ask Lewis what he wants to share. Thank you all for contributing so much and for such great questions. Yes, sir.
Well, yeah, I just have I'll try to keep it a brief story that helped me with some childhood trauma. Those of us in the room who, and it's probably a lot of us, if you're familiar with 12-step programs or attend them regularly,
Yep.
one of the things you'll hear a lot is, well, what was your part in it? And this would drive me nutty, because I'd see, oh, let's see, my part in it was I was 7.
Yep.
You know, and so one day a fellow who grew up in the oil fields of Alberta and had a rough childhood sat down with me and we were having coffee, and he says, okay, So you were 7, and how long were you in that situation? And I said, oh God, till I was 13, and I hit the streets, and I became a street urchin at that point. So okay, so 7 to 13. He goes, and how old are you now? And I was in my late 40s at the time. So you've been hanging on to this all of that time. That's your part
That's
in it.
the part. That's the
Yeah,
part.
and that
Wow,
was
that
heavy.
gave me chills, Lewis. That's amazing.
Yeah, it kind of got
Right,
to me too.
because you can't. No, you're absolutely right because we walk around sometimes like this is my bag of victimhood, right? And no, you had no responsibility in that, but I could put the bag down or I could try to put the bag down, right? So super powerful. Thank you. Yes, I am very familiar with the rooms and very grateful to for me it's Codependence Anonymous that I was very grateful to be part of. So any other questions or comments? I think we have like 2 minutes. I'm seeing so many nice messages. Thank you all.
I have a question.
Yes, Josie.
So, having this attitude of what people think about me is none of my business, is that something that is positive?
Yeah. Oh, that's a very healthy way. As long as you're not, King Konging, right? Going around killing, hurting
Right.
people without
Be
caring. But
respectful, but I may not go into a room and everybody may not like me, but my thought is, well, before I used to have to feel like I have to prove myself to people that I'm not as intimidating as I may look, right?
yeah,
I'm a very nice person, giving, caring. And so I always felt like I had to prove that to everybody before
yeah.
everybody gets the wrong impression. And
Mhm.
then so I started thinking, well, I can't go around doing that all the time. It's tiring, you know?
Yeah.
So what people
I
think
had
about
a
me is none
me-
of my business.
I love that. I had a mentor who, because I was doing so much teaching and training, he reminded me, because I would get nervous, he reminded me that I'm not trying to convince anyone of anything. I'm just sharing my experience or what I know. So you're not trying to prove to people that you're lovable or likable or anything else. You're just being who you are with kindness and compassion and all the things you do. So I think that's a great attitude personally.
Right, thank you.
Thanks.
Thank you so much, Cary. This was really a wonderful presentation, and I really love the mindfulness that we did
I'm so
and
glad.
getting in our body. So I appreciate that a lot. Uh, I'll send an email right after this with the survey, and the survey is in the chat. Scroll up a little bit and you'll find the link to it. But I'll send that in an email along with the link to the slides. There was a question about it. And check your confirmation or reminder email for full CEU requirements. You've got 2 days to finish the survey. And you can redo it as much as you want in those 2 days. You have to get 2 out of the 3 questions correct, and you can check your work while you're in the survey. If you have any direct questions, send them to the Empower Idaho email. And I think Eden will put that. Oh, she already did. She put it in the chat. And I see that Cary put her email in the chat. I'm gonna put it in again. There it is. And the slides and recordings will be on the website in a couple of days. Thank you so much, and thanks for all your great participation. It truly shows, Cary, what a wonderful presentation it was.
Thank you. And I love this comment. You've not only helped me, you've helped my clients. That makes my week. So thank you.
That gave me chills. Thanks, everybody. Have a great rest of your day. Thanks, Cary.
Thank
Appreciate it.
you. Take care.
Bye.